All right, so this is Chapter 3 of the Emergency Medical Responder course, lifting and moving patients. This is going to be one of the biggest areas where we as responding crews really appreciate our medical responders, helping moving and lifting these patients, getting them out of whatever situation they're in. You know, when we get on scene, if you guys have a plan for how we're going to get these patients out after you've done your assessment, it really helps. So let's get started. All right, quickly going over the competencies. All right, introduction. As an EMR, you must analyze the emergency situation, quickly evaluate the patient's condition under stressful conditions, and often by yourself. Carry out effective, life-saving emergency medical procedures. These procedures sometimes include lifting, moving, and positioning patients, as well as assisting other medical emergency service providers in moving patients and preparing them for transport. In some cases, your knowledge of emergency movement techniques may help save these patients' lives. Not all patients need to be moved, but if you realize that there is a life threat to these patients and they need to be moved now, this is what we're going to learn in this course. So some things to remember. Every time you move a patient, you have to keep these general guidelines in mind. We need to do no further harm to the patient. Move them only when necessary. Move the patient as few times as possible. Move the patient's body as a whole unit. Use proper lifting and moving techniques so you don't hurt yourself. And have one rescuer give the commands. This is generally the person at the head of the patient. They're going to be in charge of how we're moving them. And this prevents any confusion on what exactly it is we're doing. You know, one person instructs everybody. That's just how it goes. So some things to consider. Delay moving the patient if possible until additional EMS personnel arrive. Once again, we only want to be moving these patients a minimal amount of times and only when necessary. If there isn't a life threat, you know, we can keep them in position, wait for more people to get there to help out. We need to treat the patient before moving him or her, unless the patient is unsafe, once again. Don't step over the patient. We don't need to be, you know, getting dirt, sand, mud from your shoes or whatever, dropping onto the patient. Don't need further stuff getting in their face or stuff like that. And we need to explain to the patient what we're doing every time. Because, you know, if the patient's condition permits, they can be able to assist you. You know, maybe they're able to position from a wheelchair to the cot or out of their bed. And if they're able to help you, that helps keep you safe, keeps you from injuring yourself. All right, keep the rules of good body mechanics in mind. You need to know your physical limitations. You need to know that if you respond in your rescue vehicle to a scene, you're the first one there, and this is a 500-pound patient, you should know that you probably can't move that patient by yourself, and you're going to need some help. We need to keep ourselves balanced and maintain a firm footing. Lift and lower the patient by bending your legs, not your back. This is one of the biggest reasons people go out on injuries, on injured workman's comp, whatever, is from back injuries, from not lifting correctly. We need to try and keep our arms close to our body for strength and balance. And once again, move these patients only as few times as possible. If you suspect the patient has sustained trauma to the head or spine, we need to make sure to keep the patient's head and spine immobilized so he or she does not move it. So recovery position. Unconscious patients who have not suffered trauma should be placed in this side lying or recovery position. Once again, you get on a scene, can't rouse the patient. You suspect they might vomit or they might already have secretions in their mouth. We're going to roll them onto their side like this, And this will help keep that airway open and allow for stuff to drain from the mouth. Okay, here we're going to talk about some body mechanics. Know that improper lifting or moving techniques can result in injury to you or the patient. Your back goes out while you're lifting this patient up. You drop them, that's going to be further injury to the patient, and that's going to cause some problems. We need to use good body mechanics. Use the strength of your large muscles in your legs to lift patients instead of using the muscles in your back. All right, good body mechanics. So once again, we're going to keep our back straight. We're going to lift without twisting your body. Ensure that you have firm footing before you start to lift or move a patient. We don't want to be slipping around on gravel or sand, rocks, or whatever. We need to assess the weight of the patient and know your physical limitations. If this patient is going to be too heavy for you to do by yourself, you need to wait for somebody to get there and help out. All right. Continued good body mechanics. We're going to call for additional personnel when we realize that that patient is too heavy to lift by ourselves. We're going to communicate with the other members of the lifting team. Once again, this is usually the person at the head of the patient so that they control, if this is a trauma patient, they're going to be able to control C-spine. Otherwise, they'll be in charge and be able to see what's going on with all the members of the team. And we need to practice these lifts and moves. Practice those lifts and moves, in your firehouse with each other. All of them are outlined in this book, and we'll go over it here during this PowerPoint. All right, so emergency movement of patients. These are situations where we need to move the patient immediately due to imminent danger. These include the danger of fire, explosion, or structural collapse. We roll up on a scene of a motor vehicle accident. Vehicle's on fire. There's a patient in there who's either responsive or unresponsive. Can't get out. We need to do our best to get them out of there. Hazardous materials are present. If we can get in there without exposing ourselves or our patient to these hazardous materials. Remember, in all of these situations, we need to be thinking about our safety as well as the patient's, because we don't want to be creating more patients on scene for incoming emergency crews. If the emergency scene cannot be protected, we need to be getting them out of there. If it's otherwise impossible to gain access to other patients who need life-saving care. So we have one patient who's not in too much danger, but they're in the way of getting to patients who need our life-saving care. We need to be able to move those patients out of the way. Or the patient has experienced cardiac arrest. If they're in cardiac arrest, we need to move them. Do we need to move them off the bed and onto the floor so that we're able to perform CPR? Did they go down in a toilet stall? We need to move them out of that stall so that we have access to them. Whatever we got to do so that we can start performing CPR on those patients. So emergency drags. If the patient is on the floor or ground during an emergency situation, we might have to drag the person away from the scene instead of trying to lift them and carry them. We need to pull the patient in the direction of the long axis of the body, so from the head to wherever we need to go. This is going to be able to provide as much spinal protection as possible in these kinds of situations. So our first one is going to be the closed drag. This is the simplest way to move a patient. You grasp patient's clothing in the neck and shoulder area, rest the patient's head on your arms, and drag them away from the danger. All right, so cardiac patients in the closed drag. In most situations, you can easily determine whether the emergency movement is necessary. Cases involving cardiac arrest are the exception. If the room in which you find the patient is not large enough, we need to move the patient. We need to drag the patient from tight space and quickly move furniture out of the way in order to provide CPR. When you get in these situations, you have to determine whether you have enough room to provide CPR or not. So if not, we have to get these patients to a bigger area where we have more room to work. So blanket drag. Use this drag if the patient is not dressed or is dressed in clothing that could tear easily. We're going to place the rug or blanket on the floor and roll the patient onto it. Then we're going to pull the patient to safety by dragging the rug or blanket. These kind of drags can be useful for patients who weigh more than you do. Gives you a little bit more material to grip and pull the patient along. All right, emergency drags number 4, arm-to-arm drag. We're going to place our hands under the patient's armpits from the back and grasp the patient's forearms. These are used to move heavy patients. Does offer some protection for the head and neck. So, firefighter drag, we're going to tie the patient's wrists together, making sure to not cut off or impair circulation. Get down on your hands and knees and straddle the patient. Pass the patient's tied hands around your neck, straighten your arms, and drag the patient across the floor. I don't know that I've ever used this one myself. I imagine that if you were in a smoke-filled room, this would work well. Maybe that's why it's called the firefighter drag. All right, number 6, emergency drags from vehicle. One rescuer. We're going to grasp the patient under the arms, cradle the patient's head between your arms, and pull that patient down into a horizontal position as you ease him or her from the vehicle. We want to prevent excessive movement of the neck. Remember, this is an emergency drag. This is for when we need to get these patients out of the vehicle quickly because they're in danger of further harm. Here we can see that one rescuer drag from a vehicle. All right, emergency drag from a vehicle. Continued, 2 or more rescuers. So one rescuer is going to support the patient's head and neck, while the second rescuer moves the patient by lifting under the arms. The patient is then removed with the head and neck stabilized in a neutral position. If time permits, we're going to want to try and use a long backboard. All right, so here we have carries for non-ambulatory patients. These are patients who are unable to move because of injury or illness and must be carried to safety or moved to another location. 2-person extremity carry. Rescuer 1 is going to reach under the patient's armpits and grasp the patient's wrists. Rescuer 2 is going to reach around the legs, grasp the patient behind the knees, and the 2 rescuers will stand up and carry the patient away to safety. So, 2-person seat carry. Rescuers will kneel on opposite sides of the patient, near the patient's hips. The rescuers will raise the patient into a sitting position and link arms behind the patient's back. The rescuers place the other arm around the patient's knees and link with each other. No equipment is required for this. If possible, the patient should put his or her arms around the necks and shoulders of the rescuers for additional support. That's what this one looks like. In this diagram, the picture on the left will be what it looks like when a patient is in being carried by those two firefighters. All right, so carries for non-ambulatory patients, children. This is used by one rescuer to carry a child. Kneel beside the patient, place one arm around the back, the other under the thighs. Lift slightly and roll the child into the hollow formed by your arms and chest. I'm pretty sure everybody knows how to carry a little one. You know, we still need to be making sure to support that neck and spine. All right, here we have the 2-person chair carry, used for moving those patients. You know, if you can't pick them up out of the chair for whatever reason, this is a pretty good way to move them around. Rescuer 1 will stand behind the seated patient and grasp the back of the chair. Rescuer 1 will then tilt the chair backwards. You need to warn the patient that you're going to do that beforehand so that they don't freak out and go reaching out and throwing you off balance, causing you injury. So we're going to tilt the chair backward so the rescuer 2 can grasp the front legs. Once again, rescuer 1, who's at the head, will give the command to lift and then you're able to walk away. This maneuver is very helpful for moving patients down stairways or through narrow hallways. You can't get your cot back there. It's easy to do this and move them out to an area where you can get your cot, and then help them move from the chair to the cot. All right, so here we have the pack strap carry. This is a one-person carry that allows you to carry a patient while keeping one hand free. You're going to have the patient stand and back into the patient so your shoulders fit into the patient's armpits. You're going to grasp the patient's wrists and cross the arms over your chest. You're going to squat deeply to avoid potential injury to your back and pull the patient onto your back. And then once the patient is positioned correctly, you will bend forward to lift the patient off the ground, stand up, and walk away. I don't know that I've ever seen this one used. Seems like there's a lot of potential for back injury in this case. If they're able to stand, there's other means of moving them than this. You know, once again, these are just examples of carrying patients. All right, so direct ground lift. So this lift kind of puts your body in a bad position for using proper body mechanics, and it is discouraged. It's used to move a patient who's on the ground or floor to an ambulance stretcher. Should be used only for those patients who have not sustained a traumatic injury. The steps for performing the direct ground lift are described in skill drill 3-1. Essentially, it's two people sitting on the same side of a patient. You scoop the patient, one person at the torso, one under the legs, and then lean, because here's where the bad body mechanics come in, you lean way over the patient and have to lift them up to carry them. So that's why it's discouraged. You can see that in your book on page 41. All right, so here we have transferring a patient from a bed to a stretcher. This is sometimes called a sheet lift or draw sheet method. What we're going to do is place the stretcher next to the bed, making sure that it's about the same height as the bed, and the rails are lowered and straps unbuckled. We're going to loosen the bottom sheet under the patient, or log roll the patient onto a blanket. Grasp that sheet from across. So we're going to reach across the stretcher, grasp the sheet or blanket at the patient's head, chest, hips, and knees, and we're going to slide the patient onto the stretcher. Generally, you have one person on one side of the bed and one person on the other. So one person is pulling the patient onto the stretcher, the other one's either lifting and pushing or helping to slide them across. We do this quite often. One of the easiest ways for moving a patient from a bed to the stretcher. Here we can see that draw sheet method. Once again, you have rolling the patient onto a blanket, getting the cot set up, and you have one group of people pulling, the other group of people lifting and pushing. All right, so walking assist for ambulatory patients. Sometimes patients just need assistance in walking. This technique will be chosen after you've done an assessment of the patient's condition, the scene of the incident, and you've determined that yes, it'll be safe for this person to help you walk them out. With this one, we're going to help the patient stand. Have the patient place one arm around your neck, and you're going to hold that wrist. The other arm, you're going to reach around the patient's waist and help the patient to walk. Generally, if you grab the patient's belt on that side, assist them in standing. That way, if they do have issues, they get dizzy, they faint, whatever, they start to go down, you can help guide them down. Grabbing that belt gives you a good firm place to grasp and help lay them down. All right, a two-person walking assist. Useful if the patient cannot bear weight. Two rescuers will completely support the patient. This is pretty much the same as a one-person walking assist, except that there's a rescuer on both sides. Once again, arms go around the neck, grasp that wrist, and then your free arm goes around their waist. Once again, grab onto that belt, helps them move along. All right, so a little bit of talk about the wheeled ambulance stretcher. This is the most commonly used EMS device. Pretty much every patient we get goes onto the stretcher. It can be raised and lowered to different heights. It has belts to secure the patient. If you regularly work with the same EMS service, you need to learn how to use their particular type of stretcher so that you can help out with that while you're moving patients around. So stretchers can be rolled or carried by two to four people. If the surface is smooth, a wheeled stretcher can be rolled with one person guiding the head, one person pulling at the foot. If the loaded stretcher must be carried, it's best to use 4 people, one at each corner. That's also good advice for if you're going over rough terrain, through dirt and gravel lots, whatever. You get 4 people, one on each corner, keep it from tipping over. If the stretcher must be carried through a narrow area, only 2 people will fit. So once again, there you have one at the head and one at the foot. All right, so here we have portable stretchers. These are used when the wheeled stretcher cannot be moved into a small space. Smaller and lighter than a wheeled stretcher, can be carried in the same way as a wheeled stretcher, meaning 4 people, one at each corner. A lot of services now just use backboards for this purpose. So you might not see a stretcher like this, and patient just gets placed on a backboard, carried out, and then moved to the cot if that's what's needed. Here we have a stair chair. It's a portable moving device used to carry a patient in a sitting position. Useful for patients who are short of breath or who are more comfortable sitting. If they can't stand being laid down on a stretcher while you're moving them through the house, this might be the way to do it. They're small, lightweight, easy to carry. We don't want to use them with any patients who have experienced trauma. We're going to move patients with the stair chair same way we did with the what do we call it? The 2-person chair carry. One at the head, one at the feet. These chairs are designed for sliding down stairways, so that you're not having to carry these people down them. You sit them in that chair, lean them back. One person at the foot, one at the head. The one at the head controls everything. Once again, tip them back. Remember to warn them that you're going to tip them back so that they don't reach out, throw you off balance, injure you, and slide them down the stairs. They work pretty good. We use them a lot. Okay, next we have immobilization devices. So these are used to immobilize patients who have neck or back injuries, used to assist in lifting patients and immobilizing lower extremity injuries. Long backboards, used for moving patients who experience trauma, useful for lifting and moving patients who are in small spaces. There's a long backboard made of plastic or fiberglass. Patients must be secured with straps. If the patient has sustained a back or neck injury, the head should be immobilized. So we're going to use a C-collar and head chocks. Here we have a short backboard device. This one's called a KED. It's used to immobilize the head and spine of a patient found in a sitting position. So, if you're suspecting a head or spine injury and they're after a motor vehicle accident, sitting in that driver's seat, passenger seat, whatever, we can use this to get them out without moving their neck and back too much. They're usually made of plastic and fabric. Some consist of a vest-like garment that wraps around the patient. Here we have a scoop stretcher, helpful for moving patients out of small spaces. Do not use for patients with head or spine injuries. This device separates in half. You're going to have a left and right. Place it on each side of the patient. You're going to attach one side, either the head or the foot, and then slowly bring the other end in, kind of like a pair of scissors. and connect it at the top or bottom. And that way you didn't have to log roll the patient to get them on this. You're scooping them, just like it's called. So here we have a list of devices that can be used in an emergency situation. Wide or sturdy planks, doors, ironing boards, sturdy folding tables, full-length lawn chair recliners, surfboards or snowboards. Generally, you'll have a better option than any of these, but if you were to find yourself in an emergency situation and didn't have access to some of your equipment, these would be something that you could use. All right, so treatment of patients with suspected head or spine injuries. Anytime a patient has a suspected trauma injury, suspect injury to the head, neck, or spine, you need to know that improper treatment can lead to permanent damage or paralysis, and we need to keep that patient's head and neck in a neutral, inline position and immobilized. Keep it from moving so they don't cause further harm. All right, so applying the cervical collar. These collars are used to prevent excessive movement of the head and neck. There are soft cervical collars that do not provide sufficient support for trauma patients. Most of the ones you see are going to be these rigid cervical collars here. The orange one is the soft collar. Those white ones will be the rigid ones that we use mostly in the field. So cervical collars should be applied before the patient is placed on the backboard. Here we have top left, we have someone stabilizing the head and neck. Another person in the top right here is going to place the cervical collar. We're going to insert the back of the collar under the neck, bring the front of the collar around under the chin there, and then we're going to strap it. So movement of patients using backboards. Patients who should be transported on backboard include any patient who has sustained spinal trauma in a motor vehicle crash or fall, or any person who has sustained gunshot wounds to the trunk. So if you suspect the patient has a spinal injury, we need to move the patient as a unit. Once again, the person at the head is going to be in charge. We're going to transport this patient face up, also known as supine. We're going to keep the patient's head and neck in a neutral inline position. We're going to be sure that all rescuers understand what is to be done before attempting any movement. So we want to make sure everybody's 100% on the same page. And we're going to make sure that only one rescuer is giving the commands. Once again, that's going to be the person at the head of the cot. All right, so assisting with the short backboard device. Short backboard devices, once again, are used to immobilize patients found in a sitting position and who we suspect have sustained trauma to the head, neck, or spine. It's going to allow rescuers to mobilize the patient before moving him or her. Once the device has been applied, we're going to be able to move that patient from their vehicle or chair or whatever, wherever whatever seated position they're in, and move them to a long backboard and place them on that. All right, so log rolling. This is the primary technique used to move a patient onto a long backboard. Requires a team of 4 rescuers. Sometimes you're only going to have 2. You gotta adapt and overcome. You have to work with what you got. It's a movement technique of choice in all patients with suspected spine injuries. Procedure for that's going to be shown in skill drill 3-4. That's going to be on page 51 of your book. Just once again, something to remember with this is that everyone has to understand who's in charge, who's directing the maneuver. I'm going to keep saying it over and over again. It's going to be the person at the head of the cot. They're going to be the one in charge of telling us how and when we're going to move. So we need to be listening. All right, so all patient movement commands have 2 parts, a question and the order for movement. In your book, it talks about rescuer 1 says the command will be ready roll. When everyone is ready to roll the patient, rescuer 1 says ready. This question is followed by a short pause to allow for the response from the team. The rescuer 1 then says roll. Generally we do 1, 2, 3, roll. Everybody rolls, slides the backboard under. 1, 2, 3, everybody rolls the patient back. It's just as long as everybody understands the commands and when to move the patient. That's what we need to do. We need to remember to move the patient as a unit, so everybody moves their part at the exact same time, and we need to keep the patient's head in a neutral and inline position at all times. All right, here we have the straddle lift. This can be used to place a patient on a backboard if you do not have enough space to perform a log roll. Some modified versions of the straddle lift are commonly used to remove patients from motor vehicles. So it's just another way of getting them on the backboard. So the straddle lift, this one's going to require 5 rescuers, 1 at the head and neck, 1 to straddle the shoulders and chest, 1 to straddle the hips and thighs, 1 to straddle the legs, and 1 to insert the backboard under the patient. If you're going to use this lift, it should be practiced often. So to use this lift, the person at the head of the patient will instruct a lift. You're going to lift the patient 1/2 inch to 1 inch off the ground and then slide that backboard in there. The most difficult part of this technique is coordinating the lifting so the patient is raised just enough to slide the backboard under the patient. Once again, team coordination can be difficult, so the lift should be practiced often. So the straddle slide, this is a modification of the straddle lift. In this case, the patient is moved rather than the backboard. Once again, person at the head is going to instruct a lift. Everybody's going to lift the patient and then slide the backboard, or slide the patient onto the backboard. This may be useful when the patient is in an extremely narrow space. Once again, we're going to lift the patient as a unit, slide the patient forward about 10 inches at a time. Each rescuer should lean forward slightly and use a swinging motion to bring the patient onto the board. So once we have the patient on the board, we have some strapping techniques. Every patient who's on a backboard should be strapped down to prevent sliding or slipping. The strap should be long enough to go around the board, and a large patient. Straps 6 to 9 feet long with seatbelt type velcros work well. So once the patient is centered on the board, we're going to secure the upper torso with straps, secure the pelvis, upper legs, using padding in any voids behind the back wherever we need to, and then we're going to secure the head. So to secure the head, generally we use commercially prepared or improvised devices. The blanket roll is an improvised device that works well. Should be readily available just about anywhere. You should have blankets or sheets or something in your truck to create this. Like I said, most of the time we use a commercially prepared head chocks, head rolls. So head stabilization must be maintained through the entire procedure. That means that you need to be holding C-spine the entire time until you get that head secured to the blocks. These rolls or head chocks must be fitted securely against the patient's shoulders. And then we're going to secure that blanket roll or head chocks to the head with 2 cravats tied around the blanket roll, and then we're going to use 2 more to bind the head and blanket roll to the backboard. This is an example of some foam blocks that are sometimes used. They're quick to apply, provide good stabilization of the head and neck. We use a different type. They're foam rolls that go under the head on a roll on each side, and then they get taped down to the board to keep the head from moving. So in summary, we want to remember that in most situations we can treat our patients in the position found, and then when other EMS personnel arrive on scene, they can assist, and we can assist in moving the patient. Sometimes that's not possible, and the patient's survival may depend on your knowledge of emergency movement techniques. Every time we do move a patient, we need to remember to do no further harm to them. Move the patient only when necessary. Move the patient as little as possible. Remember to move the patient's body as a unit. We need to use proper lifting and moving techniques to ensure our own safety, and have one rescuer give commands when moving that patient. We need to remember to always use good body mechanics when we move these patients. Know our own physical limitations and capabilities. We need to keep ourselves balanced when lifting and moving a patient. Maintain a firm footing. Lift and lower the patient by bending your legs, not your back. Keep your back as straight as possible at all times and use your leg muscles to do the work. We need to keep our arms close to the body for strength and balance. And once again, move that patient as little as possible, as few times as possible. Unconscious patients who've not sustained trauma should be placed in the recovery position until further EMS assistance arrives. If the patient is on the floor or ground during an emergency situation, you may have to drag that person away from the scene instead of trying to lift and carry that person. Remember, we do not want to lift or move a patient if we suspect a spinal injury, unless it is absolutely necessary to remove the patient from a life-threatening situation. EMS services typically use wheeled ambulance stretchers, portable stretchers, stair chairs, long backboards, short backboards, and scoop stretchers. A cervical collar will prevent excessive movement of the head and neck. Log rolling is the primary technique used to move a patient onto a backboard. And once the patient has been secured to the board, we need to immobilize the head and neck. Quick review. As an EMR, you may injure your back even if it is straight if you A. Lift with your back bent forward at the hips. Align your shoulders over your hips. Hold your hands close to your legs or use your leg muscles. Remember, we need to keep our backs as straight as possible when lifting. So the answer on this one would be A, so even if you keep your back straight, if you bend forward at the hips, there's a possibility of injuring yourself. So remember to keep that back straight, don't bend it. All right. Number 2, patients who should be transported on a backboard include any patient who is intoxicated, requests it, has an upper extremity injury, or has sustained gunshot wounds to the trunk. Generally, if they're intoxicated, we don't backboard them. I don't know why anybody would request it. Any upper extremity injury isn't a reason. Remember, backboards are for suspected spine injuries and sustained gunshot wounds to the trunk. So it would be B. All right, number 3, head immobilization is not required on all patients who are placed on backboard. Can be achieved using head blocks or towel rolls. Does not need to be maintained during the backboarding process. Or D, can be properly accomplished with only special equipment. So A, it is required on all patients who are placed on a backboard. C, it does need to be maintained during the entire backboarding process. And it can be accomplished with other items, like we talked about, towel rolls, blanket rolls. So our answer is going to be B. Can be achieved using head blocks or towel rolls. All right, so that was the end of Chapter 3, Lifting and Moving Patients. We'll see you on the next one.